alternative of treatments for osteonecrosis of femoral head. First, we have to the definition of the avascular necrosis is disruption of circulation of the femoral head. The death of the bone can produce joint degeneration. This pathology is approximately produced in 1 per 1,000 people between 25 to 45 years, averaging 38, and is responsible of 5 to 20% of total hip replacements in USA. Is very common. The cause of physiopathology of these illnesses could be traumatic pathway or non-traumatic pathway. The traumatic pathway is related with hip dislocation or proximal femoral fracture. These conditions produce vascular disruption and critical ischemia and produce necrosis. In non-traumatic pathway, is another conditions that states hypercoagulable conditions in the body, that these conditions produce thrombus formation and critical ischemia. The most frequent non-traumatic etiology is steroid-induced. Approximately 25 to 50% of necrosis could be produced for steroid-induced. Alcoholism is another risk factor, and another illnesses like sickle cell anemia, decompression disease, Gaucher, syndrome antiphospholipid, lupus, tumors, radiation, and approximately 25% of these pathologies we don't know why these are idiopathic. When 3 to 25 of patients treated with steroids developed osteonecrosis. That depends of dose of these steroids. More than 20 milligrams per day of prednisone is more risk to develop this condition. The initial dose is very important to develop this condition. The diagnosis is performed by clinical evaluation and some images. In some cases, it could be necessary to do another exams like PCR, rheumatoid, autoimmunity, etc. But the main, in the most cases, the clinical evaluation with X-ray or MRI is the diagnosis could be done. X-ray is the first imaging sensitivity in early stage is 41%. Is very low. For this reason, we don't use to perform the diagnosis in early stages. But in later stages, we can see flattening, collapse, and degenerative changes in hip joint. TC scan can show us morphology, extension of injury, of subchondral bone, but sensitivity is in early stage is very low to 55%. MRI is the gold standard image to perform diagnosis, and sensitivity and specificity is 99%. especially in pre-collapse injury. We can see typical images of in MRI to perform it. He always we can search in another hip because approximately 50 to 70% could be bilaterality. There are many classifications. Ficati-Arlet was one, Steinberg, and ARCO is the most important and most used in this moment. This ARCO classification is reviewed in 2019, classified in 4 stages. 1 and 2 stages don't have collapse. In stage 3, we have subchondral fracture. If we have femoral head depression less than 2 millimeters, is 3A, and more than 2 millimeters of depression femoral head is 3B. In ARCO 4 is evidence of osteoarthritis, joint space narrowing, and degenerative acetabular change. About the treatment, this article is very interesting. I recommend this. This was published in 2020. And we have non-operative treatment for this. We have observation, weight-bearing restriction, bisphosphonates, anticoagulants, vasodilators, aspirin, extracorporeal shockwave therapy, pulse electromagnetic fields, hyperbaric oxygen. All of these treatments, non-operative treatments, are have grade of recommendations I, because don't have enough scientific evidence in the literature. But in forward, we can see a little more about this. Extracorporeal shockwave treatment, you can see in this article published by C. et al. And Algarni. We can see hip survivor in the right side, 81 to 95% of hip survivor in pre-collapse. We can see all of these treatments, non-operative treatments, are indicated in pre-collapse stage. Operative treatments are recommended in pre-collapse stage and post-collapse stage 2. We can resume core decompression, multiple small diameter drilling, cell-based therapy, non-invasive bone grafting, vascularized bone grafting, osteotomies, and in post-collapse stage is recommended total hip arthroplasty with grade of recommendation A. Core decompression is most widely used, decrease elevated head pressure, improving pain. The failure rates is 5% in medial lesions. In more failure rates is in large lesions, like you can see in this publication that by Leverman. Okay. Core decompression can is a joint preservation surgery, improve blood flow, decrease intraosseous pressure, and is indicated in pre-collapse phase. Core decompression can show us only core decompression can show us survival of the hip head, approximately 87 to 86% of survival in follow-up of these studies. What we can do after drilling, after core decompression, we can perform vascular cell bone graft, non-vascular cell bone graft, or autologous bone marrow, mesenchymal stem cells. There are many articles about this, but in creeping substitution, in this stage, we can induce the revascularization of the bone doing core decompression and putting some kind of graft, maybe vascularized, not vascularized, or bone marrow concentration. Core decompression mast cell therapy, the study most important in my opinion, is the Hernew and et al. Published in 2018, indicating pre-collapse bone marrow, and it was compared with only core decompression, and the results are much better in core decompression plus bone marrow mesenchymal stem cells in compare only with core decompression. New techniques like stem cells, BPM or Tantalus rods don't have enough evidence to recommend it. Bone graft don't have a very rare, very high of rate of evidence. In non-operative treatment, we have the shock waves. The shock waves are mechanical waves to put in the skin, and these waves pass through the tissue until bone. In this mechanical stimuli in the acts in the cellular membrane and induce cellular response. This response is producing different substances that can improve the circulation in the bone, can produce osteogenesis, and produce many kinds of molecules like plated endothelial cell adhesion or another cells. In conclusion, that produce increase of vascularization in the bone and increase of osteogenesis, like this study. There are many papers talking about this. I am showing some of these papers. This Italian experience for this. In this systematic review, extracorporeal shockwave therapy in osteonecrosis of femoral head, reviewed in total 17 articles, and the conclusion is the shock waves is safe and effective method to improve the motor function and relieve the pain in patients with osteonecrosis of femoral hip. I think this is the one of the most important paper that confirms that the shock waves is there and very effective. This paper was published in 2012 by one, and in this study analyzed long-term outcomes of extracorporeal shockwave therapy and core decompression for early osteonecrosis of femoral head with 7 to 9 years old of follow-up. In this study, includes 48 patients with 57 hips, including 23 patients with 29 hips in the extracorporeal shock waves and 25 patients with 28 hips in surgical groups. The objective of this study is compare the treatment with extracorporeal shockwave treatment and core decompression, and follow up 8 to 9 years old. 23 patients, extracorporeal shockwave with 29 hips, 25 patients with 28 hips, core decompression order. The groups are very similar. You can see the demographic characteristics of the patients are very similar. Number of hips, average gender, size, duration of symptoms, all are very compared groups in shockwaves and surgical group. In results, we can see the hip survival. First, we can see in weight group, the survival of the hips are 22 of 29. Number of total hip arthroplasty is 24. In compare, in surgical surgical group in core decompression, the number of the total hip arthroplasty are 64%. It's very clear in the shockwave groups is have better results to survival. The same results in pain is better results in shockwave groups. You can see the follow-up 8 to 9 years old. The pain score is less in compared to surgical group. The same results in Harris hip score. Best results for shockwave groups. Sites of lesion is similar. Sites of lesion in the shockwave groups are lesser than surgical group. You can see the imaging resonance in the right hip before extracorporeal shockwaves at 6, 12, 24, and 36 months after treatment. You can see the evolution in MRI and X-ray. In shockwave groups don't have complications. In surgical groups have morbidity of donor of average of 58%. In conclusion, the extracorporeal shockwaves is more effective than core decompression and bone grafting in femoral head. But there are many controversial results. In some papers have very good results, in another don't have very good results. What type of waves we have to do? High energy equipments, electrohydraulic equipments. I will show some cases. Case 1 is 38 years old, male, pain in both hips. 1 year after, in the right side, in the left side, it's 1 year is after 1 year is another in the right side radiography, X-ray. We performed this treatment 8 years before. And you can see the MRI. You can see the stage 3 or 4. We perform core decompression, shock waves, and this patient had a very clear change of joint degeneration, but have 8 years of follow-up, but don't want to perform total hip replacements too. Another cases is male, 43 years old, bilateral, reduced. You can see the stage 3, same. We perform core decompression, shock waves to improve results. This patient have 1 year after. Until now, we have 2 years of follow-up. Have a little pain, but he don't want to perform total hip replacements too. Another case, male 33. You can see the severe change in the right hip. To this hip, we decide to perform total hip replacement, and in the left have femoral acetabular impingement. We perform shockwave, hip arthroscopy, and bone marrow cells, and core decompression and shockwave. This is the final of these patients. In the right hip, have total hip replacement. In the left hip, we are dilating for the total hip replacement, but we are waiting because it's very young patient. Conclusion: if we have hip or groin pain in young adult patients suspecting osteonecrosis, it's very important to perform early diagnosis. For this reason, that depends on the results. Always thinks in bilaterality. Shockwaves are safe and effective. The evidence for cell therapy is increasing. In pre-collapse stage, we combine core decompression and shockwaves. And post-collapse, we think in another techniques and maybe in total hip replacement. Young patients try to delay arthroplasty. Thank you very much.